And that's the actual receipt that when they bought me, when they paid the adoption fee of $8 to adopt me. So that's what it cost back in the 1960s. There have been other traumas upon traumas, and my work now in public health in British Columbia, we have seen, obviously trauma related to the pandemic, the COVID pandemic, the toxic drug poisoning crisis, the recent climate change events in our province, flooding, landslides, heat-related deaths. There's still violence in communities. The picture on the top right is meant to portray the recovery of bodies of children in unmarked graves at the sites of former residential schools. And lastly, the picture on the bottom is meant to represent racism and racism in different systems. In this case, the health system. This is Joyce Echaquan, who died while receiving care in a hospital in Quebec. And her death triggered a whole discussion nationally, provincially, territorially, and locally around racism in the health system that I hope will lead to change. I've had the chance to meet her family virtually, and I know how important she was. She was the key figure in that family, and they have to go on without her. So we have to continue to work together to make change so that deaths like Joyce's don't happen again. Now, I'm not going to spend too long on this slide, except to say that there have been report upon report upon report. They are all very important. So because I'm not speaking to each one individually, doesn't mean that I don't think that they're important. As far as my career goes, these have been spanned by the Royal Commission on Aboriginal Peoples that took place in around 1996 was the final report. The Truth and Reconciliation Commission of Canada, the Calls to Action, the United Nations Declaration on the Rights of Indigenous People, which was adopted in 2007 by the United Nations, but not until 2010 by Canada, because Canada was one of only 4 countries that opposed the adoption in 2007. The report of the missing and murdered Indigenous women and girls in 2019, and 2 local reports that, 2 provincial reports that I've been a part of. The In Plain Sight report, which documents racism, widespread racism in BC's healthcare system, and the most recent report from 2022, which my team at First Nations Health Authority, we were so honored to bring forward and gift to the BC health system, particularly Fraser Salish region, called Remembering Keegan. This is a case study reflection of a young man who died because his presentation to the emergency room was both misdiagnosed and neglected, and his life was his death, was preventable. And so this report contains a documentation, a narrative of his experiences in the hospital, but stops at different places to give cultural teachings and cultural safety learnings for healthcare professionals, so that, again, a death like Keegan's hopefully can be prevented. So, when I talk about these historical events, these contemporary traumatic events, the intergenerational trauma, these reports, which I do feel are important, I think one act of reconciliation that people can do is to read through these reports. Some of them are lengthy. There are executive summaries of most of them, but not only think organizationally or at the level of Renison College University, but personally or on your team or within your program or department. How can you answer these calls to action or calls for justice? There are many different recommendations. For example, in the Missing and Murdered Indigenous Women and Girls report, there are actually calls for justice for all Canadians. Those are some of the last recommendations in that report. So really good things to reference and have a look at. But part of reconciliation does involve discomfort. So when I was talking about those last 3 slides, I'm sure people were thinking, oh my gosh, it's a downer. She's going there, she's staying there, she's going to go on and on about this. And that's not my intention, but my intention is to invite you to feel that discomfort, because that discomfort is necessary in order to create the space for listening and for learning, and then together in partnership moving forward. And a lot of times, I get asked to do these types of talks, but really it's for non-Indigenous people, for non-Indigenous leaders of organizations to do the heavy lifting and to look really starkly at themselves, what the history is, some of the systemic policies that have excluded Indigenous people and other people of color from different positions, different opportunities, etc. So this slide is a whole kind of mishmash of things, that slogans and memes that I've come across, that all of them sort of speak to truth, right? One of my colleagues, Marcia Anderson, is a physician, an Indigenous physician in Manitoba, and this is one of her top tweets. And I think this is really relevant for people who work in this area, for people who teach and work and attend Renison. From now on, instead of vulnerable people, I'm going to use the phrase people we oppress through policy choices and discourses of racial inferiority. It's a bit longer, but I think will help us focus on where the problems actually lie. So that is something that I've heard a lot over the past number of months or years, so that we stop using that phrase, vulnerable people, and we start talking about people in situations of vulnerability and why those situations exist in the first place. So it does require a bit of discomfort, and that's going to take some time. But to help you out, for example, there is a post, if you're active on social media, by Bryson Syllaboy, and his Twitter handle is in the diagram on the right. 30 things to know about Indigenous allyship. Now, these are his opinions. He feels strongly about certain things, but that again is that discomfort. Because we are trying to reconcile, it is important to create that space to listen and to learn. I'm going to give you an example that's positive. Last week at this time, I was just landing in Calgary for the conference, the big Canadian conference on medical education. And as part of that, this is called the National Consortium for Indigenous Medical Education. The picture you see of the 6 of us all smiling are the 6 Indigenous physicians who founded this consortium. So myself, Dr. Marcia Anderson is the tallest in the picture. Dr. Sarah Funnell is to her right, Dr. Lisa Richardson. To my left is Dr. Evan Adams, and to his left is Dr. Darlene Kitty. Now, we are some of the most senior Indigenous physicians in the country, and we have shown by our ability to make partnerships that an Indigenous-led national medical organization is possible, and that we can both take our place in leadership of medical education and our rightful place in Canadian medical history. And we have, 6 work streams. I'm not going to go into a whole bunch of detail, but we intend and we are determined to both change the face of medical education in this country. But as you can see from the picture, we support one another. There's no competition between the 6 of us. We love each other. We have joy in our work. And it's really a pleasure to share this as an example. Finally, just a couple quick slides. So I have mentioned, the truths must be told and heard and acknowledged before reconciliation can happen. And this is one of my all-time favorite quotes that's accompanied by this emotional artwork by Kent Monkman called The Scream. But this is one of my favorite quotes that I hope you remember. This is by Senator Murray Sinclair, who's now retired, who also chaired Canada's Truth and Reconciliation Commission. Reconciliation will not be achieved if one side believes it is based on the recognition of rights and the other believes that it is an act of benevolence. And lastly, I'm going to get back to the one sky for all, because when I was reading about the motto, it immediately made me think of Richard Wagamese, who was an unbelievable Indigenous writer who left us too soon. He died a few years ago, but this was something he wrote in 2015, and this is what I will close with. All my relations. I've been considering the phrase all my relations for some time now. It's hugely important. It's our saving grace in the end. It points to the truth that we are related. We are all connected. We all belong to each other. The most important word is all. Not just those who look like me, sing like me, dance like me, speak like me, pray like me, or behave like me. All my relations. It means every person, just as it means every blade of grass, rock, mineral, and creature. We live because everything else does. If we were to collectively choose to live that teaching, the energy of that change of consciousness would heal all of us and heal the planet. We do it one person, one heart at a time. We are connected. We are the answer. And I'll just end at the very end with one of my favorite memes. And this is how I approach my work. So it's really interesting as a 60 scoop survivor that I have tried to reclaim as much as possible. I have been in touch with my biological family. And in order to do this work, in order to lead, in order to press for equality, diversity, inclusion, anti-racism, one has to be strong because it takes a lot of emotional labor. So I love this last one. You know, you are who your ancestors sang about in their ceremonies. I love that. Anyway, I'll end it there. All my relations, Miigwech. And I guess I'm able to take any questions.
From the room, and we'll alternate back and forth. And for anybody that is asking a question in the room, there are microphones in the room, so you don't have to move. Just speak clearly and the microphones will pick you up. And the floor is yours. Would anybody like to start with a question for Dr. Wieman?
Dr. Nalla, you spoke of, I think the name was Bison Syllaboy, and the 30 things you should know about Indigenous allyship. Can you, I don't know that, but I'd be interested in finding it. I'm wondering if you could correct me if I'm wrong on the name. Is it a YouTube site?
Yeah, no, he's on Twitter, but I have already shared my slides with the organizers today in a PDF format. So I'm not sure if I'm happy to share those slides in that format. So I guess if you contact the organizers, they might be able to provide that. And on that slide with that graphic, you can see his Twitter handle.
Thank you.
I'm told that can definitely be shared. So.
Okay. I see a question in the slide, the chat, sorry, that says, can you please talk in more detail about your current work in BC? So I'd be happy to. So, you know, I have had an interesting journey, I will say. I practiced psychiatry for 20 years in a variety of different settings. The first 8 years I worked on reserve at the Six Nations of the Grand River Territory, which I'm sure most of you are familiar where that is. And then I moved to downtown Toronto I had a bit of an academic career, took a bit of a break and worked mainly in research, did some clinical work with some small Indigenous agencies in downtown Toronto, and then did some clinical work for YWCA Toronto. And then I spent my last 5 years before I moved out west working at the Center for Addiction and Mental Health. And then I was recruited to First Nations Health Authority, where I now work. And First Nations Health Authority is a whole presentation in and of itself, but it's the first Indigenous, First Nations led health authority of its kind and of its scale in the country. We have the entire province. So we work for the 203 BC First Nations communities in that province. So I have made the transition to public health. And initially, most of my work was in the area when I first got there, because of my background in psychiatry, was in things related to mental health and wellness and substance use. So for example, actually today, there was just an announcement from the province that they have made amendments to the Mental Health Act in terms of involuntary status of patients to try to improve safety and make it less dangerous or risky for patients, particularly Indigenous patients who are being held involuntarily, because there have been some really terrible examples of how people have been treated. And now, the last 2 years have been really a challenge for everybody. So most of us, because I work now, there's about 7 medical officers at First Nations Health Authority where I work. I'm the deputy chief. I have a chief medical officer that I work for. And we were all attuned to the COVID-19 crisis. So the first year was a bit of a blur. We were trying to manage all the outbreaks in different communities across the country, or across the province. The second year was mainly the vaccination rollout. And the whole time we did a lot of public health messaging. So for example, we spoke about the mental health impacts of the COVID-19 crisis. And then, of course, in British Columbia, you may have heard in the news, we also have the second public health emergency, which is what we now call the toxic drug poisoning crisis, which used to be called the opioid crisis. And we have observed a terrible collision between COVID-19 and the toxic drug crisis. So in 2020 and 2021, we experienced an acceleration of deaths and toxic drug poisoning events for the entire provincial population, but specifically for BC First Nations people. We lost many, many more people, 25% increase from 2019 to 2020, 25% increase from 2020 to 2021. So the 2 major files I work on now are the toxic drug crisis and cultural safety and humility. So trying to make health services, health programs safer and anti-racism work.
Thank you. And another question from the room. Not seeing any currently. Another question online?
Yeah, I'm just seeing it in the chat. I'll repeat it for people in the room. It said, this week we saw Ryerson University adopt the name Toronto Metropolitan University in recognition of past harms. Can you share from your perspective how names make an impact? I mean, I think it's really variable and diverse. It's really hard for me to say that there's one reaction to names and naming. I think, every Indigenous, First Nations, Métis, Inuit person would probably have a different answer to that. But I do think in general that names are important, naming places, naming buildings. You've seen probably examples in the news of statues being pulled down. I know for myself, it's interesting since the pandemic, when you go to pay for something, everything's on, tap now. I don't even bring a wallet. I just tap my phone. But I can tell you, I used to really dislike carrying currency around because I'd see Johnny McDonald all the time. And he's, for me, someone that I don't really feel a strong affection for. So I think it's different. And it was like I was sharing kind of in my talk, you know, I recognize with compassion that that delegation that went to Rome really felt that they needed to see the Pope. They needed to go, they needed to have that audience, they needed to hear those words. But for myself personally, I didn't really hear an apology. I heard an apology for certain individuals who may have wronged, but I didn't hear an acknowledgement of the systemic problem of churches, the Catholic Church in this case, and the harms that were inflicted upon the attendees of residential schools. So for me, I was feeling wanting more. And like I said, I felt I had a really strong reaction to him getting, you know, the Pope getting a traditional name. So, but I acknowledge that that's my own personal reaction. And other people felt that they got some closure from that trip. So I think we all just have to really understand where each person is coming from. I'm glad they changed the name of Ryerson University, and I think that will cause a lot of places to think and consider. I think this, like I said, that's where the discomfort comes in. We have to sit and think about why these things are named in the first place, right? Whenever I go to a beautiful park here in British Columbia, there's always a plaque to somebody who's usually non-Indigenous who discovered this place, right? But they really didn't discover it because it was lived in. These were trails that were crossed. These were trading routes. These were trails people used to visit each other in different communities. Like that's, I think, the thing that annoys me is that the history is quite recent and it's also revised.
Thank you. Another opportunity for questions from the room. Is there any indication of how many questions we have online?
There is a question, there was a thank you, so I'll say you're welcome. There was one more question about, can I talk about discussions happening in the Canadian psychiatric landscape, education and practice with respect to reconciliation and decolonizing practices? That's a really interesting one. For the last couple of years, actually recently, on a weekend, I gave a talk to the Alberta Psychiatric Association. And I would say, you know, I always speak pretty bluntly, actually. I'm trying to be on good behavior to a certain extent today, but psychiatry, I think, has a ways to go. And I kind of took people to task a little bit at that meeting, because, for example, they asked me to come and give a talk on the intergenerational trauma related to residential schools. And my first reaction to that was, wow, that's a really deficit-based way of looking at it. I get that you want to understand more about people's experiences, but we also have to focus on, you know, resilience and strengths-based approaches and how to be more culturally safe. So I kind of took what they asked me to speak about and I talked about it for a few minutes, and then I spent the rest of the time talking about what I wanted to talk about and what I wanted to share with them. And I think they have a real, that field, I challenge them, and I challenge them every time I speak to psychiatrists, because you know, we only have maybe, I don't have the accurate number really, but I would guess there's probably only about maybe 15 Indigenous psychiatrists in the country, maybe 20. I'm not sure. I don't think there's that many. So I challenge them to think about, why is psychiatry not a specialty that attracts Indigenous medical school graduates? Because the need is so great in communities. And when I say communities, I mean both First Nations, Métis, Inuit communities, and I mean on reserve communities and urban communities. Everywhere, the mental health needs are so great. So I think psychiatry actually has to take a good hard look at themselves, and I'm not going to be the one to have the answers for them. I was honored to practice as a psychiatrist because of that relationship that I was able to form with the patients that I saw. But I didn't engage too much with the profession as a whole because I, to be honest, I had some pretty racist experiences, the worst ones being with my peers. And that happens, you'd be surprised. You know, I've been in meetings as recently as a month or two ago and have experienced racism with psychiatrists. And I've had psychiatrists, when they first met me, when I moved out to the West Coast, I had one fellow woman psychiatrist ask me 3 times if I was a real psychiatrist. Like she said, like, but you're real, right? Like you're a real psychiatrist. You did like a real psychiatrist. And I was like, I don't want to have anything to do with you. Because sometimes it's, you know, like I said, the work is a lot of emotional labor. It's very heavy work. And I don't really want to, obviously I want to make change, but I don't want to put myself in a position over and over and over again of experiencing racism. I've pretty much done it my whole career, but now I think my tolerance for that has gotten a little bit lower.
Thank you. And we do have a question in the room, please. Yeah. Yes, Dr. Wieman can hear you. Yeah.
What you're hopeful for, those sorts of comments.
Sorry, could you hear that, Dr. Wieman?
I couldn't. If you could repeat it, that would be great.
So the question was if you could speak more about the toxic drug crisis and your experience of that, and any thoughts and anything that you are hopeful for moving forward.
Yeah.
Sorry, hopeful and or concerned about moving forward. Thank you.
Well, I would say my major concern, I mean, in order to keep it relatively brief, would be that in British Columbia, for example, I mean, this is where I'm situated, so I'm speaking from my experience here in BC, is that we just passed the 6th anniversary of the opioid or toxic drug crisis being declared a public health emergency in this province. So it almost doesn't make sense that something has been going on for 6 years and yet it's still a public health emergency. So that's one concern, that it's been going on for such a long time. And really the crisis was going on before it was declared a public health emergency. I guess the second concern obviously has been, like I mentioned, that terrible unintended consequence of increased deaths during the pandemic. And we recognize that that was partly more in the beginning because of the public health advice around physical distancing and, you know, isolating. Initially, we went into lockdown. We didn't have lockdowns, I don't think, that were quite as severe as the ones that were in Ontario. But people were moved, you know, from congregate settings into single room occupancy buildings. People were using alone and they were dying alone. So there's been the interaction between that. And I guess my last concern is, you know, there were so many resources and the rapid response thrown at the COVID-19 pandemic. And of course, we benefited from those funding opportunities and addressing the pandemic crisis in our province and for First Nations people and as part of our work at FNHA. But, you know, we still haven't seen the same urgency, the same urgency, the same caring with the toxic drug crisis as we have with the COVID-19 pandemic. And in fact, in British Columbia, we have lost more people in absolute numbers to the toxic drug crisis each year than we have to COVID. So I have always been saying for a couple of years now that, the messaging around the COVID-19 pandemic is, we're all in this together. We have to look out for one another. We have to be kind. We have to be calm. We have to be safe. And that's true. But that's not the messaging for the for the toxic drug crisis, right? Where a lot of people think, oh, I'm glad it's you and not me, or that doesn't have anything to do with me at all. When in fact, people who die from toxic drugs come from all walks of life, belong to all sorts of different communities. And of course, we have lost way too many people. So what we're doing about it at First Nations Health Authority is, I would welcome you to go to our website, actually, it's fnha.ca. We were the first health authority out of 7 in the province of BC way back when, before I even got to FNHA, that developed a 4-pillar, framework for action that talks about keep people who are using from dying, or people who overdose from dying, keep people who are using safe, all the way to the spectrum of supporting people on their healing journeys and preventing substance use in the first place. And we do so many things. It would take me too long to describe all of them, but we have, made, we distribute both naloxone and nasal naloxone throughout the province into communities. Probably the biggest initiatives that we're working on right now is nurse prescribing models. So trying to have increased access to OAT. So nurses, registered nurses and nurse practitioners, registered psychiatric nurses can prescribe OAT if they have the training. We are also working on access to prescribed safer supply, meaning people would be able to, mostly now through virtual and some in-person clinics, have access to prescribed safer supply. So that would separate them from the toxic drug supply. And BC, you may or may not be aware of, has put in a Section 56 exemption application to Health Canada for decriminalization of substances for personal use. So we are waiting to hear the results of that, but I think we feel pretty positive that that's going to happen, and that carrying small amounts of substances for personal use will be decriminalized. And we're just about to embark on a series of regional engagements with BC First Nations in June to talk with community leaders about what decriminalization might look like for them, especially in rural and remote and isolated places.
Thank you. Last opportunity for questions from the room. All right. Thank you very much, Dr. Wieman, and I would like to invite Wendy back to offer more substantial thanks.
Thank you, Dr. Wieman. I'm going to stand on the opposite side of the podium so I can look at you, if that's okay, because I can't see if I look at the others. It really is a privilege for me to take a moment to express our deep gratitude that you have made space in the complex world and work that you do to tend us, to hear us, to open up space for us to understand in new ways. The critical impact of your work struck me very strongly this week. I was in your world briefly visiting relatives in Vancouver. My Haida niece, moved about 6 years ago after I left BC to Vancouver. I'd never visited her in her home before, so she gave me her address. The occasion was the 14th birthday of her granddaughter. I was going with my little rental car to pick her up and her daughter and her granddaughter, so we could go and have some white spot to celebrate this 14th birthday. Her address was East Hastings Street, about half a block west of Maine. And as I pulled in to park my car and to jump out to embrace my relations, I saw the face of the world they're living with, which I've seen with others before, but never embracing and cradling people who have moved very closely in my heart. That reality, the world that you are with and that you work daily to work toward shared empowerment in and with saves lives daily, saves them. It's a matter of life and death. And I just want to say that it's not just a matter of the abstract here, that the work that you're doing is about my relations. It's about all our relations. It's about the survival of all of us with a vision for a world that can sustain life and hope and healing and health. And without your contribution and the wisdom of you and others who are willing to walk with people who have yet to understand more, it would be much harder to get there to the other side, to the world that we all hope and can imagine and long for. So I thank you with my whole heart. Miigwech.
Thank you. I raise my hands to all of you for listening to me, and I will have to step away, but I hope you enjoy the rest of the evening. And miigwech so much for having me. I wish I could have been there and seen you. But I hope that you have a lovely rest of your event, and it's really been an honor for me to be here with you today. So take care.